Good afternoon, everyone, and welcome to today's health chat. We're going to get started in just a few minutes. We're just going to let everyone join who was in our waiting room this afternoon. So just be a moment, and we'll get started with our conversation today. Good afternoon, everyone. My name is Joel, and I'm with Adventist Healthcare, and I will be moderating today's health chat. Check your rear view, understanding colorectal cancer. Before we begin, we have muted everyone to limit any background noise. During today's health chat, if you have any questions for our experts, please put them in the Q&A at the bottom of your screen, and we'll be sure to get to as many of them as our time allows today. We ask that you please only submit general health-related questions, and for any specific health matters, we encourage you to speak with your healthcare providers. We are recording today's health chat for future viewing, and that will be accessible on our Adventist Healthcare blog. Today, we have two exciting experts to discuss the topic of colorectal cancer. Dr. Vivek Patil is a colorectal surgeon with Maryland Oncology Hematology at Shady Grove Aquilino Cancer Center, and Dr. Vinni Juneja, who is a medical oncologist with Maryland Oncology Hematology at White Oak Cancer Center. Thank you both for joining us today, and we're going to go ahead and get started with our first question. So our first question today is actually, we're going to start with you, Dr. Juneja. Our first question is, what is colorectal cancer?
Yeah, thanks for the question. So I think the best way to visualize your colon is kind of like a plumbing pipe. So your colon's very, very flexible, though. It's not anywhere like the rigidity of a pipe, but just kind of think about a pipe and how water flows through it. And if you look at the inside of like a PVC plumbing pipe, like a brand new one, right? It's very smooth on the inside, and water can pass through it, and all other substances can pass through it easily. So the colon is similar. It's very smooth on the inside. It's got some folds and it's very flexible. But when the best way to visualize it is when the inside starts to get a little bit rough in the colon, it starts to get irritated and the cells start to change slowly over time. And sometimes they can form what's called a polyp, which looks like a tiny mushroom or like a tiny button, might just be a few millimeters. And then over time, the cells in the polyp may or may not be cancerous, but over time, over many years, they can slowly change their DNA in the cell and start to mutate into cancer cells. So generally, they start as non-cancerous or precancerous, and very slowly over the years become cancerous cells and slowly enlarge. And because the colon is so flexible, there's a lot of space in there. Stool passes through the colon, and if there's like a big polyp or a tumor sitting in the colon, stool can still pass through it, and you may not feel anything at all until it really gets quite big and is starting to block everything up.
So you described colorectal cancer for us. What are some of those early symptoms of colorectal cancer that we should be on the lookout for?
Well, in terms of like how you feel, like I said, it's a lot of times it does not cause pain until it is quite big in the colon. But definitely, belly pain is like a big warning sign, and it's not necessarily colon cancer. I mean, it could be your appendix, it could be your gallbladder, and other things. But definitely pain, and it could be pain anywhere in the belly. Another big one is any change in your bowel habits. So, like, if you just start getting chronic diarrhea out of the blue for no clear reason, that can have a lot of causes, but one of those could be a colon polyp or cancer. Definitely blood in your stool, or I know no one admits they might want to look in the toilet after they go number two, but any change consistent change in your stool size, like consistently getting smaller, or if you find yourself straining a lot to go to the bathroom consistently, that you never really had a problem before with. All these changes could be a sign of colon cancer. They can be a sign of something else too. But those are the big symptoms to watch for.
So if someone is experiencing those symptoms or just want to be proactive with their health, what diagnostic tests could be performed to identify colorectal cancer early?
Well, the best test is a colonoscopy. That is a gold standard. It does take a lot of commitment from you as a patient. You have to prep for it and take a prep that essentially will give you diarrhea, like you had really bad food poisoning for several hours. And the better you prep, the more accurate the colonoscopy. But if you don't prep well, the colonoscopy simply can't see a whole lot because there's stool covering the colon. And when we're talking like little polyps that might be 1, 2, or 3 millimeters, you really can't see those sometimes if that's covered under stool. So the colonoscopy is the best test. Obviously, a lot of people don't want one, or sometimes they can't get one for medical reasons or transport reasons. So then, sort of in second best test are the Cologuard test, which is a test on your stool to look at your stool DNA, and that test involves collecting some stool and sending it in the mail to a lab, and it will look for polyps and cancer. It's about 90% um, accurate for cancer and about 50% accurate for precancerous polyp. There's another new test, which is a blood test, which sounds very appealing. It's called Garden Shield. It's a blood test to look for any circulating tumor DNA. That is about 80% accurate. So I think if you combine the Garden Shield with the Cologuard, and if you can't get a colonoscopy, it's a pretty decent way to screen. It's definitely better than nothing. Um, as a third kind of set would be just a simple test of your stool for microscopic blood. And a lot of general docs and cancer docs offices have that test. You basically swab your stool in a card, and we look for microscopic blood. And then just a simple blood test to see if you have iron deficiency anemia. One of the things that can cause that is bleeding cancers in the colon or the stomach.
Okay. So what age should someone begin receiving regular colonoscopies? And on the opposite end, is there a certain age that they could stop receiving those colonoscopies or colorectal cancer screening?
Well, it used to be the gift of true middle age when you hit 50, the big 50, you were eligible for a colonoscopy. But because worldwide there's been an increased incidence of colon cancer for people under 50, the age has been lowered to 45 instead of 50. And I believe that the same would apply not just for colonoscopy, but for the Cologuard and the Garden Shield as well. And generally, we stop doing them around the age of 80 as a ballpark. It's just tough to tolerate the prep and then the sedation for the colonoscopy. People have a tough time coming out of it after approximately the age of 80.
Thank you for sharing that for us, Dr. Juneja. I appreciate it. Um, Someone asked if they've had a colonoscopy and they're not due for another one in a few years, how could they be sure that they're not developing cancer or anything's happening in the meantime?
I think the regular follow-up, let's assume you never had cancer. I think just regular follow-up with your general doc, at least yearly blood work. Um, if you can put up with the stool test as well in the interval between colonoscopies, whether it's Cologuard or just the Hemocoat, which is the blood test. Um, those are good ways between the blood and the stool and your physical exam. Um, those are good ways to screen for colon cancer if you've never had colon cancer.
I would like to take this moment to ask Dr. Patil. I have a few questions for you on this topic as well. One of the questions that we received is, what happens if a colonoscopy comes back abnormal?
So if a colonoscopy comes back abnormal, it depends on how abnormal. So one of the benefits of a colonoscopy in distinction from the Cologuard or a blood test is that it is not just a diagnostic tool, it's a therapeutic tool. So a blood or stool screening, if it's positive, will then necessitate a colonoscopy. So you're sort of doubling your screening now. Whereas at a colonoscopy, if you see something abnormal, you can at oftentimes remove it. And at the very least biopsy it, know where it is in relation, sort of anatomically. So as Dr. Juneja was saying, these polyps that are you may encounter as a provider, and approximately 20 to 30% of the population will have polyps on colonoscopy, so it's not a small number. When we find them, we can remove them at that time. Now, obviously, if something is too big to remove, then all we can do is biopsy and try to figure out what it is. And so it can range from you found a polyp, which is technically sort of an abnormal colonoscopy, and on biopsy, it's completely benign, it's nothing. That would not change what we do. It would sort of still say, you would still say your next colonoscopy interval is 10 years. If there are abnormalities of polyps that are something called adenomas, which are the precursors of cancer, then that usually shortens your interval of colonoscopy. So you'd have to have it in 5 years instead of 10, assuming that the provider is able to remove all of the polyps. If there's something that's not removable through a colonoscopy, then oftentimes it may require surgery. And that would be, of course, cancer, or at times even a very large polyp that just could not be removed through the colonoscopy.
Thank you for sharing those with us, Dr. Patil. An additional question that I received in reference to polyps was, what dietary and lifestyle changes should a person make to prevent polyps from forming? Do you have any recommendations on that?
Sure. I mean, there's no hard and fast rules that we can point to that prevents polyps, because frankly, we don't have clarity on why they occur. There is likely some genetic component to it, and I think there have been some studies that have showed some genetic component. There are hereditary diseases that cause you to form a tremendous number of polyps in the colon. It's called polyposis syndrome, and those are definitively gene linked. But people who just form sporadic 1 or 2, 3 polyps in the colon, those people generally don't have an identified genetic disorder. We just find them, we remove them. We know now that you are capable of growing them, so we shorten the interval. And the bottom line is that there's nothing we can really do to prevent them. We just have to keep on top of them, which is why it's a 5-year interval instead of 10. Now, there are some studies that have shown particular medications in the ibuprofen family that may help. You'd need to consult obviously with a physician, because these are prescription medications. But generally, we feel that healthy living should help decrease polyp formation and certainly cancer formation. That is, high fiber diet, healthy, not, as little processed food, red meat as you can take, moderate alcohol, stop smoking if you smoke, exercise, good water intake. All of these things can help sort of make the gut a healthier place and less likely to form these polyps.
Thank you for sharing those practical tips with us, Dr. Patil.
Sure.
We received a couple of questions in reference to hemorrhoids and their association with colorectal cancer. So the first question that we received that I'd like to ask is, how are hemorrhoids or irritable bowel syndrome and inflammatory bowel disease different, and how do these impact your risk of colorectal cancer? Could you answer that for us?
Sure. So hemorrhoids are normal veins inside of the rectum, and they can get enlarged with any kind of pressure placed on the rectum. So chronic constipation, diarrhea, childbirth. So people with irritable bowel syndrome, which is not necessarily a disease process, but sort of a condition where the gut is very hypersensitive to any kind of stimuli, whether that's what you're eating, your stress, and that has different manifestations of abdominal pain, bloating, constipation, diarrhea. Just depends on how it affects you. But it's a benign condition, but it can be very troublesome symptomatically and also hard to treat. So someone with IBS most likely will have hemorrhoids, and they don't, neither of those things increase your risk of colon cancer, but they can create symptoms that may mimic colon cancer. So that, as Dr. Juneja was saying, sometimes some abdominal pain, rectal bleeding from the hemorrhoids. These things you may say, oh, well, I've had bleeding my whole life because I've had IBS, irritable bowel syndrome, or I have frequent abdominal pain and bloating. And, those symptoms just sort of get written off to IBS. But if you're not screening, then you actually don't know, and these symptoms might be masking something more insidious. So that's it's not directly related, but that's how it's sort of peripherally related. IBD, which is called inflammatory bowel disease, is Crohn's disease or ulcerative colitis. These are autoimmune conditions that affect the gut that cause inflammation and these sort of very difficult symptoms that occur as a result. This condition is a definitive diagnosis made by a gastroenterologist with blood testing, endoscopy, and will require usually lifetime medication. These conditions have a direct increase in risk for colon cancer because of the autoimmune chronic inflammation. And these require more frequent screening with colonoscopy. But most of the time, once diagnosed, you're under the care of a gastroenterologist, and they're kind of supervising that whole thing.
Thank you for providing that answer for us. Dr. Patil, I have just two more questions for you. I know you have to step away a few minutes early, so I'll ask these two for you real quick. The first one that we have is, what healthy lifestyle habits should someone who has undergone colorectal surgery adopt after that surgery?
I think what we alluded to before, the health of the gut is something that we are beginning to understand. We, as a medical community, have sort of ignored it for many decades prior to this, but we understand now that the gut moderates a lot of our health. And so keeping the gut healthy and happy is important for, prevention of recurrence for cancer. It's not entirely airtight that one would be able to prevent colon cancer by being healthy, but it certainly plays a role. It helps with mood. It helps with general health. So it's overall a good strategy to employ. Basically, there are resources all over the internet that you could find in regards to what is a high fiber diet? How do I keep a healthy gut microbiome? How do I exercise properly for my age? What's good hydration? So these things, certainly you could talk to your primary doctor about, but that is very important for anyone looking to prevent recurrence after colorectal cancer surgery, or those who are looking to try to do everything they can to prevent or onset of colorectal cancer. Obviously healthy living, making sure you're sticking to the screening guidelines. These are the most important things.
That last question I have for you, Dr. Patil, before you have to step away is, what is the likelihood of recurrence after treatment for colorectal cancer?
It depends on the severity. So when we diagnose colon cancer, we like to stage it. Not only like to, but we must stage it. And this is based on a few factors of how far the tumor may have invaded into the wall of the colon, has it spread outside of the colon, and using these metrics between the initial biopsies, the radiology, meaning a CT scan, and also, of course, the pathology once the tumor is removed during surgery and checked out by a pathologist, they can give us all that information to figure out the stage. And there's 4 stages from 1 to 4, 1 being the earliest and 4 being metastatic disease when the tumor has spread to other organs. And the rate of recurrence depends on what stage it is. So very early stage has an extremely low risk of recurrence, and as a result, surgery is often the end of the treatment. In people with stage 3 or above, sometimes advanced stage 2 even, chemotherapy is indicated, and that is the role of chemotherapy is to prevent recurrence, essentially, to destroy any lingering cells that may be floating around the bloodstream that we can't see. We use chemotherapy to destroy those.
Thank you for answering that question for us. I do want to just take a moment to address our audience. Dr. Patil, I appreciate you joining us today for this conversation. We're going to continue on with some questions for Dr. Juneja. I do want to encourage those of you who are listening today to, if you have any questions for our experts, please just drop those in the Q&A for us, and we'll have Dr. Juneja answer those for you at the end. But thank you again, Dr. Patil, for joining us today.
Thank you.
Thank you. All right, and Dr. Juneja, we have a couple questions on genetics. Some people were really interested in knowing about the genetic factors that might increase the risk for colorectal cancer. Could you explain how those factors can impact risk?
Yeah. So the overall concept is if you look at a cell in your body, it looks like a fried egg. It's basically got yolk in the middle and then the white part on the outside. And that yolk in the middle is your DNA in the cell. And the DNA in the cell, when it accidentally mutates, or if it was you were kind of born with a mutation, it can turn on at a unpredictable point in your life and start mutating. And when that DNA mutates, slowly that cell becomes a cancer cell and then starts outgrowing the other cells that are non-cancer cells, and then the cancer is formed and starts growing. So the genetic factors, as Dr. Patel touched on, there's this syndrome where you have a lot of polyps in your colon called familial adenomatous polyposis, and that's where your colon is essentially full of polyps from a young age, like as soon as like middle of high school, and that's clearly caused by a genetic factor in that the yolk of the egg in the DNA of the cell. That's not super common. It runs in families, and it's kind of obvious when you do a colonoscopy because the entire colon is covered in polyps. The more common one is called Lynch syndrome, or big long name, hereditary non-polyposis colorectal syndrome. In this syndrome, again, there's a defect in the DNA, and it chooses to express itself at different times in life, and it may not express itself at all. But generally speaking, above the age of 30 is if it expresses itself, will start expressing itself, and it might not express itself till you're 80 or 90 even. And the clue in this is we look in the colon tumors on the pathology for some changes in the DNA that is linked to this, but also just if you're just looking at your family history. If you have a family history of colon or uterus cancer, that's a signal for potential Lynch syndrome. And even if you're healthy, but you have a family history of the cancer, you can get genetic testing through a saliva test or a blood test. We do them in our office for people who don't have cancer. I generally don't advise the commercial test that you can do it yourself, like 23andMe. The accuracy is very questionable, and definitely some bankruptcies out there in these companies. So we're never quite sure what the accuracy was. Our commercial tests are generally covered by insurance. Generally, if they're not covered by insurance, usually we can talk to companies into charging about $200 to $300 for an out-of-pocket expense for the genetic test. And you'll know in about 3 weeks if you do choose to get genetic testing.
Hey, thank you for answering those questions. I think it's important to realize that genetic factors are at play and that there are resources out there to discover your risk and the genetic factors that can impact your risk. So thank you for sharing that with us, Dr. Juneja. We have two final questions to ask, and then we do want to address some of those questions in the Q&A. So again, if you have any questions you'd like to add, we encourage you to include them. The first of our two final questions that we have is, we hear a lot that colorectal cancer is occurring more and more frequently in younger adults in their 20s and 30s. Is there any explanation as to why that's occurring, or any information you can provide for us on that, Dr. Juneja?
Yeah, that's a very, very good question. No one knows the answer, and by the time we know the answer to that, multiple generations of people will probably have passed, because the research is hard. But our best educated hypothesis as a medical community is the following. Cancer in general is increasing worldwide, regardless of country, amongst people less than 50. And there has not been, to our knowledge, a genomic shift in our population in the past 20 to 30 years that would account for that, because evolution just doesn't happen that quickly. Therefore, it must be environmental. And it's unfortunately, it's in the food, the air, the water, and it really, you can control what you can to minimize these risks, but short of moving to a different planet, you can't really get away from things such as microparticles of plastic in the water that we know harm animals. So it's only logical that it will harm humans. Whether it's bottled water or tap water, these microparticles of plastic are everywhere, and they're a consequence of our modern living, that we're also reliant on plastic. You're breathing them in as we speak. I mean, I'm breathing them in just from your clothing, what's made of synthetic fabric. It's just literally surrounding you. So you're breathing it in, you're drinking it in, and it's going to affect some people more than it affects others. We don't understand which genome is at risk for this and which isn't. So like I said, you control what you can. So Dr. Patil said, things that you can control, for example, red meat intake, that is definitely linked to increased risk of colon cancer. Obesity is linked to increased risk of colon cancer. Eating more nuts is linked to a decreased risk of colon cancer. We don't truly understand why. Eating more fiber, especially with your breakfast, decreases your risk of colon cancer. And in general, it's just the concept to think about is whatever you're eating through your mouth is sitting in your gut for maybe like 12 hours, maybe 3 days. Everyone's bowel movements are different. So whatever you're eating and drinking is going to sit in your gut. And do you want your gut exposed to whatever it is? You just have to ask yourself with everything you eat. We know pesticides concentrate up the food chain. Does it mean if you're vegetarian, you're never going to get colon cancer? No, it unfortunately doesn't. So you control what you can with your lifestyle, but you have to realize a lot of things are not in our control.
Thank you for addressing that for us, Dr. Juneja. And the last question that we had as just a final question before we get to the Q&A was a question about the future of colorectal cancer treatment, and what does that look like, and are there any innovative technologies on the horizon for treating and diagnosing colorectal cancer?
Yeah. So Dr. Patel will never be out of business. He's a fine surgeon, and we will always need surgeons. I don't think surgery will be eliminated for colon cancer anytime soon. Um, Now, usually the surgery is not a enormous surgery the way like a heart bypass might be in terms of risk to the patient. So we will always need surgery for many cases of colon cancer. For rectal cancer, which is basically down low near the buttock, um, we, in select cases, are not doing surgery for rectal cancer because what we're using is chemotherapy and radiation to try to kill off the tumor. And if it's completely killed off, we have about 3 to 5 year follow up from countries all across the world. Well, what if you just don't do surgery? And it seems that a decent number, maybe half of people, will stay in remission without surgery for these tumors. Again, this is closer to the buttocks, but they're cancers that are quote unquote higher up, which is basically maybe near your rib cage or down on your right side. Those still need surgery right now. So the chemotherapy is there, it is effective, but it just doesn't eliminate the need for surgery.
All right, we're going to take just a few moments here. I want to encourage anyone who may have questions for Dr. Juneja to please put those in the Q&A, and we're going to get started with the first two that we have here. The first question that we have, Dr. Juneja, is does regular constipation increase your risk? Is that an increased risk factor for colon cancer?
Um, I think it it doesn't clearly chronic constipation. Um, I think it would depend too, because if you're constipated because of the tumor obstructing you and the constipation is newer, then I would definitely be more worried. But if it's something like, well, my gut only passes a bowel movement every 2, 3, 4 days, and that's just the way your gut is, it's just slower. It's not a known increased risk factor.
And the last question that we have here, and again, if anyone else has any questions they'd like to add, I encourage you to do so. The last question that we have currently is, can probiotics assist with colon health and prevention of colon cancer?
Yes, I think, again, we don't have any study to prove to you that if you eat yogurt a lot or you take probiotics, that you will decrease your risk of colon cancer. But as Dr. Patel said, there is a known risk between your bacterial composition of your gut and the risk of colon cancer. So taking probiotics does restore the gut bacteria to good health if you're not already taking those bacteria through your diet, which primarily is through things like yogurt. Um, so I think there's definitely no downside to probiotics and definitely a potential upside. So I do think it's worth it if you're not getting enough of those bacteria in your regular diet.
Actually, I've seen a couple more questions come in. One of the questions that we just received, Dr. Juneja, was in reference to blood in the stool and if that is a definitive sign that something is wrong. Could you just describe that for us?
Yeah, it's not a definitive sign that you have cancer. I mean, hemorrhoids is probably the number one reason. If you have a cut in your buttocks where the stool passes through, that can be another reason. But blood in the stool is something we take pretty seriously. So at any age, it's worthy of checking out. Definitely. Just go to your general doc or just go to a gastroenterologist and have it checked out. It's worth it. And that would include also black stool. Stool should not be black unless you're taking iron pills. So if you have black stool, you want it checked out too.
Okay. All right. And an additional question that we received was if there's any correlation between colon and breast cancer or colon and other cancers, if there's any connection between them.
There is in those genetic syndromes that I mentioned with the association with uterine cancer. I would say that's the biggest thing to watch.
Okay. All right. Well, I'm not seeing any more questions coming in. So, Dr. Juneja, we're going to go ahead and conclude our conversation today. I want to take just a moment to thank everyone for joining our health chat today. If you're interested in other wellness classes and future health chats, please visit adventisthealthcare.com and click on classes and events for the latest information. For more information on cancer services at Adventist Healthcare or to learn more about today's experts, please visit adventistcancercenters.com. And Dr. Juneja, I want to thank you as well as Dr. Patil for answering our questions today. And we appreciate all the wonderful information that you both provided. And I hope everyone has a great rest of their day today.